So my co-chair, Bradley Kwan, and myself, we would like to welcome you in this session of CFTR-related disorders. Brad Kwan is an adult pulmonologist, and he's an associate professor at the University of British Columbia in Vancouver in Canada. I am Elke de Wachter. I'm a pediatric pulmonologist at the University Hospital UZ Brussels in Brussels, Belgium. I'm also the coordinator of the ECFS Diagnostic Working Group together with Nick Simmons, who is an adult physician at the Brompton Hospital in the UK. Brad and I, we will be chairing the session regarding CFTR-related disorders because since the publication of Bombieri in 2011, an updated guidance on definition, evaluation and management of people with a CFTR-related disorder is needed because there has been an immense increase in the understanding of the disease liability of the different CFTR mutations in the last decade. So the first speakers of this session, they will be basically highlighting the theoretical background, and after each speaker we will have some time to discuss. And then the second part of this talk, two other speakers, they will discuss the same case, however, from another perspective. So let me introduce to you the first speaker, Carlo Castellani. Carlo is a pediatrician and a medical geneticist. He currently works in the CF Center in Genova, in Italy, and he worked on different ECFS consensus initiatives, which resulted in recommendation papers, standard of care papers, consensus papers. He currently is the leading author of the new CFTR-related disorder recommendations. This initiative has been set up about 2 years ago, together with a core group of members of the Diagnostic Working Group. So we kindly invite Carlo to share the content of his work. We have no disclosures as...
Just a reminder of our questions as well.
So about the questions, there is a Q&A button, but of course, the second part of this session will be rather more interactive, so there are some microphones in the audience in case you want to ask lively your question. So, Carlo.
Thank you, Elke, and thank you also for asking me to speak at this interesting and potentially challenging symposium on CFTR-related disorders. My task today will be to tell you why the European Cystic Fibrosis Society decided to invest in this, why we did it, how we did it, what has been done and what still has to be done for a better understanding of CFTR-related disorders. I have nothing to disclose concerning this specific topic. Now, as far as I know and I'm concerned, all this started quite some time ago. There was a meeting in Italy, an international meeting supported by CFS and the European Society of Human Genetics. Maybe you can recognize some faces and a small figure there. And that was the meeting which eventually produced a paper on the consensus and the use and interpretation of CF mutation analysis in clinical practice, which has been, I think, for a long time a useful aid for physicians in dealing with mutations. That meeting worked with small groups, and in one of the small groups, this uncertain area, this foggy area of clinical conditions which were not really CF, but definitely had to do with CFTR, was discussed. And it was then that it was suggested that perhaps CFTR-RD was the right term for them, and it was decided to create a panel of experts to try and detail better what the problem was and how to diagnose it. That was and still is a controversial issue, and it was not easy to find an agreement among so many different opinions, but eventually in 2011 the paper just mentioned by Elk was published, and the recommendations for the classification of diseases as CFTR-related disorders. And that has been, I think, again, a useful paper for a very long time, and sort of a reference paper, the Bombieri paper from the name of its first author. Now, more than 10 years after, a lot of things have happened, and perhaps it's time to think again about how we define CFTR-RDs and add to what was known then something new, because a lot has happened since. A lot of NGS analysis performed in these 10 years, and a lot of new variants identified, and quite a few of them associated with disorders like CFTR-RDs. More data collected, more genetic and clinical data collected by databases we use to assess disease liability of the variants, CFTR2, but also other databases like CFTR France are available for that. A lot of more ICM and NPD measurements performed, and so more awareness of what electrophysiology can tell us in this specific field. Longer follow-up of newborns or babies with inconclusive diagnosis after newborn screening, what in Europe we call CF-SPID, and in the US CRMS, because it is a possibility that some of these children over time develop a CFTR-related disorders, as it is shown that some of them develop cystic fibrosis. And finally, CFTR-related disorders, people usually think of bronchiectasis, or pancreatitis, or CVAVD, but there may be other disorders which, at least in some cases, may be related to CFTR, and so be CFTR-related disorders, and that has to be considered too. So the Diagnostic Network Working Group of ECFS created a small core panel. A project was designed, and the project is about creating documents, 4 documents on this topic. The first 2 have already been published recently in JCF, and I'll focus more specifically on the first one, updated diagnostic criteria, which is trying to give more information about how to use the definition of CFTR-RD that you can find in the Bombieri paper, and I'll get to that in a minute, but also gives some general info on follow-up and diagnosis. While the second one is about biomarkers of CFTR function that, again, are part of a definition, or the dysfunction of CFTR is part of a definition, and that was produced by a group coordinated by Isabel, and maybe Isabel is telling something more about that later. So we went through a literature search and through deleting not relevant papers and grading the others, we ended up with a relatively small number of papers, some of them of not exceptional quality. The topic is inherently difficult to tackle, so this did not surprise us. So the definition, and this is the definition in the paper: a clinical entity associated with CFTR dysfunction that does not fulfill the diagnostic criteria for CF. We believe it is still a very good definition of a CFTR-related disorders. What perhaps is needed is to be a bit more specific about at least 2 of the 3 components of this definition, and so clinical entity. What sort of clinical entities are we actually talking about? And CFTR dysfunction. How do we measure CFTR dysfunction when we are assessing someone for a possible CFTR-related disorders, and where do we draw the line? So we consider these 3 components of the definition one by one, started with the easy one, excluding CF. We have a definition of a diagnosis of CF. The old Rosenstein and Cutting paper is still working well. We all know that to make a diagnosis of CF, we need clinical manifestations consistent with it, or a positive IRT at birth, or a CF sibling, plus either a positive sweat test or 2 CF-causing mutations, or consistent electrophysiology test results. And this works very well even today for the vast majority of CF cases. Things get a bit more complicated when you think of the phenotypes that may be associated with CFTR-related disorders, and traditionally 3 of them have drawn the attention and are mentioned in the Bombieri paper: CBAVD, acute recurrent or chronic pancreatitis, bilateral bronchiectasis. But there are others where an increased frequency of CFTR mutations or cases of borderline sweat tests have been reported. And so it makes sense that for at least some cases of ABPA, chronic rhinosinusitis, primary sclerosing cholangitis, and aquagenic wrinkling, actually we could be considering a CFTR-related disorders, and this has to be assessed, and it's part of the future work. I'll tell you how we'll deal with that. Also, in the previous paper, CFTR-related disorders were mainly defined as mono-organ disorders. So you would expect them to be mono-organ manifestations, perhaps with some exceptions. But we wonder if this is really the case. Just an example, if you think of a male with CBAVD, just refer to a CF center, and there they find that there are mild, very mild signs of lung disease. The sweat test is borderline. Does that make this person a person with CF? Wouldn't it be more sensible to keep the CFTR-RD definition and follow this person to see if actually something serious, something more than a very, very mild mild lung manifestations evolve? That was a reason for discussion, a difficult discussion in the group. To help us ourselves with the decision, we created this list of pros and cons associated with either the mono or the poly organ definition of CFTR-RDs. I'm not going through all of them. You can find them in the paper. I think it's a quite exhaustive list and exhausting. Well, okay, you got me. And eventually, the decision was to state that CFTR-related disorders can also be polyorgan. And the third component of a diagnosis is dysfunction. There must be CFTR dysfunction, but what does that actually mean? We suggest 3 possibilities. One is in vivo or ex vivo dysfunction in the CFTR-RD range in at least 2 different CFTR functional tests, sweat test, NPD, or ICM, or 1 CFTR variant and evidence, again, of in vivo or ex vivo dysfunction in at least 2 functional tests, or 2 CFTR variants shown to reduce CFTR function with at most 1 CF-causing variant. Now, Mutations are included in this definition. They're only indirect markers of function because we are all aware that some electrophysiology tests like MPD or ICM are available only in a minority of CF centers, and that would have greatly limited the potential for diagnosis and non-considering mutations. And this is another way of looking at it, the combination of tests for dysfunction, assessment through biomarkers, and mutations. The mutations include at most one CF causing, as I said, and in the second paper there's a list of mutations frequently associated with CFTR-related disorders. And there are also some situations which are still in the gray zone. There's still a lot in the gray zone in this area. When you have one biomarker, one test for function, which says that there is dysfunction, but you don't have the two mutations, and that's an uncertain situation still. There's also a flow chart, and again, I will not go through all of that, and maybe Isabel will do that later, which uses the mutation analysis and the biomarkers with the different exits in the end, and it could be potentially useful when assessing someone with this clinical suspicion. But there is also a small flow chart, a clinical flow chart. The diagnosis of CFTR-related disorders here is divided in two moments, different outside the CF clinic and inside the CF clinic. And this is because what usually happens is that the first suspicion comes to mind not to a CF physician, but to, I don't know, a non-CF pulmonologist, a gastroenterologist, a urologist, or andrologist, depends on the CFTR-related disorder. Now, what we would expect is that this person, first of all, exclude other causes of what he is seeing in non-CFTR-related disorders. For example, for a pancreatologist should exclude other causes of pancreatitis. When this is done and the suspicion persists, the final assessment should be done in a CF clinic. We do believe that a diagnosis of CFTR-RD should be done by a CF clinician. It's a complex diagnosis. The tests are usually made in CF centers. And so once in the CF center, following the three components, the first thing to do is to exclude that's not mild CF. Then check the dysfunction using the three definitions I just mentioned, and if in the end it all fits in, a diagnosis can be made. And once that is done, the other question is this mono-organ? Is it polyorgan? Is there anything else more compared to what moved the physician to send this person to the CF clinic, something which has not been properly investigated before? And you can do that going through a clinical history, examination, clinical investigation. Again, there are some flow charts, and I'm not going through all of them, but they may be helpful, but they may also be modulated according to the kind of CFTR-related disorders you're dealing with. But I think it is very important that once you have a diagnosis, you're sure that if there is something else somewhere in the organs usually affected by CF. Also because that could change again the diagnosis. And there's also a checklist after the first assessment, looking at checking that all the proper information has been given to the patient and understood, and setting a rhythm and periods for the follow-up, Ideally, these patients should be followed at least once a year in a CF center or in a CFTR-related clinic in a CF center. This may be impossible for a number of reasons, and if it can be done, this person will be followed by his or her GP or for the original physician who sent him or her to the center. But this colleague and the patient himself should be aware of some warning signs which may indicate the need to anticipate the visit at the center or schedule a new one, because things may change over time, and a diagnosis of CFTR-RD may also change into a diagnosis of cystic fibrosis over time, depending on the quality also of the clinical manifestations or of some biomarkers that may change over time. It's also important to check how the patient has coped with the information and if he needs psychological support, and if possible to provide that. That's what has been done, but there is work in progress, and another document will be about the individual disorders. So there are small groups of experts who will work on the single disorders. For instance, for CBAVD, they'll have to answer to a number of questions. What is the definition of CBAVD? How is CBAVD diagnosed? Are there CBAVDs that are not CFTR-related disorders? And then some indications on follow-up and treatment. And the same for pancreatitis, bronchiectasis, and of course, I think it's quite clear that follow-up and treatment cannot be and may not be the same for someone with mono-organ CBAVD and someone with mono-organ bronchiectasis. And the same will happen also for these other conditions I mentioned before, but here it's not completely clear yet if we can call them CFTR-RDs or not. So all these questions will be preceded by another question. For instance, for ABPA, is there enough evidence to include ABPA, or some cases at least of ABPA, among CFTR-RDs? And then the other questions. And finally, the final document is going to be a mixture of different topics, not necessarily related one to the other, but all very important in this context. One of them, for instance, is the CFTR-RD registry. Do we need one? And what would the source of data be? Has it to be merged into the CF registry or an independent registry? How to monitor the quality of the data and to support it? Another group will explore the potential of CFSPID and CRMS babies to develop over time as CFTR-RD disorders. And then the big chapter on dissemination. As you've seen, the first contact with a possible CFTR-RD person is probably from someone who's not in the CF field, not reading a CF journal, not going to CF conferences. So we'll have to find a way to communicate to them as well, to speak at their meetings, to write in their journals. It's also important to focus on treatment. That would deserve a full talk probably, but it is a fact that some people with CFTR-RD are treated with CF treatments. This changes a lot according to the physician's attitude and to the possibility to prescribe or not these treatments. But the fact is that we don't have any clear evidence that these treatments may be helpful. Theoretically, they could, because of course there is a dysfunction of CFTR function. But there are no clinical trials, so it's important to think how this clinical trial should be designed, what endpoints, how they can be sustained. And finally, genetic counseling particularly challenging because these disorders are characterized by a high phenotypic variability. So what sort of genetic test, how deep should we look for them? Should we propose the test also to the extended family? What about prenatal diagnosis? All the difficult questions. And with that, I finish. I hope not too late. And first, let me thank all the other components of the core group, Chris de Boek, Elke, Kevin Sauern, Isabel, and Nick Simmons. And thank you all.
Thank you very much, Carlo, for this presentation. There are 3 questions in the Q&A chat. The first question is nasal polyposis alone a sign of CFTR-RD that needs the whole workup?
Well, there have been some literature, some cases in the literature, also for nasal polyposis, suggesting that there may be a connection. We don't know that yet, but maybe you noticed that the group working on the upper airways has vague definition, not necessarily only on chronic rhinosinusitis. So they are expected to assess in a large sense the upper airways diseases that may potentially be CFTR-related disorders.
Could I maybe tag on to that question? And each of these individual manifestations have poor specificity on their own for CFTR-related disorder. To what extent do you involve the specialists in those areas, whether it be ENT, gastroenterology, and have multidisciplinary case discussions in these cases?
Now, there are small groups, 5 people. They were chosen for their specific expertise in individual disease. Each group includes a person from the core team who has well in mind how the guidelines were developed and may assist and importantly make them coherent one with the other in a way that they all think in the same way and making their own decisions. The definitions now have been better defined, so it will be a matter of searching the literature and finding if indeed there are situations which satisfy the diagnostic criteria. I completely agree on the fact that it will be a small minority of cases, but it's important to be aware that this is a possibility.
Move to the next question. Would you interpret it as a CFTR-RD with a negative sweat test, but homozygous for a 70-11TG background with Pseudomonas colonization?
Well, probably I needed to know a bit more about this case, but I think that a negative sweat test does not necessarily rule out a CFTR-related disorder if other biomarkers are consistent, if the genetic supports it, and if it's, of course, one of the clinical phenotypes I mentioned before.
Next question is, what should centers do that don't have access to more advanced physiologic testing, such as intestinal current measurements or NPD? It may be a topic for the next discussion as well.
Yes, as I said, that's exactly the reason why I include the mutation analysis. Otherwise, this would have been the diagnosis for an elite of a few centers. Of course, patients can be referred to these centers, but I think that CFTR-related disorders, even if a minority of cases, especially in the new situations we are considering, on the whole, are not such a rare event. So I don't know how sustainable that would be. And centers who can't access these tests and they don't or can't send them to another center have anyway a diagnostic possibility and putting together the sweat test and mutation analysis.
question. One last question for you, Carlo. How often is it suggested to recheck a chloride value, just with new symptoms developing, or only at fixed times in recommendations?
Now, I don't think we specified that. I would say definitely if something new happens, no doubt about that. I'm not so sure that if you manage to follow a CFTR-RD every year and nothing clinical is happening, it is that useful to repeat the sweat test. It doesn't hurt, but maybe it's not so indispensable.
Okay, thank you very much. Then let me introduce you Tanya Gonska. She's a pediatrician in the Department of Gastroenterology at the Sick Kids Hospital in Toronto, and she's the leader of the research team in translational medicine. Her interest focuses mainly on diagnostic biomarkers, especially different sweat testing techniques, but also MPD and ICM, and therefore she's the ideal candidate to tell us something more about clinical biomarkers and sweat chloride for the diagnosis of CFTR-RD. Please.
Good afternoon, everybody. I have to open my slide. The start. Oh. And then I use it. For the first one, you have to click. All right. Thank you very much. It's great to see so many people interested in that topic. Thank you very much, Brad and Elke, for inviting me to talk. So I will continue where Carlo left that off and talk more about CFTR function. I have no relation, no disclosure to this talk. A brief outline. I want to discuss about available CFTR functional tests in a brief way, discuss a little bit advantage, limitations for clinical use, discuss test disagreement. A couple of cases, don't want to take away from the big case discussion, but just to show you a little bit the disagreement and future research outlook. So while it is difficult to identify thresholds of CFTR dysfunction, what is normal, abnormal, I do believe it is important to strive for more accuracy in identifying CFTR-related disorder patients. One is because to have an etiology for the patient's symptoms. Another one is to identify those requiring CF specialized care, and this may include CFTR modulator therapy in the future. And the other one is also to focus our resources on those really at risk for disease-associated CFTR defects. So the sweat chloride concentration test following sweat stimulation with pilocarpine iontophoresis was the first CFTR functional test developed by Gibson and Cook. And what it does, so I use here the cursor, it measures when you sweat, you measure the sweat chloride concentration on top of your skin. And that is followed and now standardized with the Westcott method, pilocarpine iontophoresis, then a sweat collection cup. Some people use still the gauze, which is fine, but then you need a laboratory step to measure the chloride concentration. So advantages is an easy access organ, the skin is everywhere, relatively easy to use, implemented globally, standardized as much as possible, but it does require lab equipment, and a high sweat chloride can happen in non-CF controls, but also low sweat chloride concentration is seen in CF patients. So the classic sweat chloride test can very well distinguish between somebody who does not have the disease and a severe CF patient with pancreatic insufficiency. But when you look further and you look in patients where we want to know the diagnosis, you see here, these are old studies by me and Michael and Peter Dury's cohort, that those with one mutation and no symptoms, or chronic silent pulmonary disease, CVIVD in one mutation or two mutation, do overlap with CF patient controls. So while it nicely shows a disease spectrum, it doesn't really help your individual case if you want to put him in a disease risk category. So then people have developed another way to measure CFTR function, this time at the baseline of your nasal mucosa, and it measures the potential difference between a catheter sitting on your nasal mucosa and one in the skin, so it measures across like an epithelium. And you can then stimulate a CFTR function, and then, or you see no function, like in people with CF, or you do see CFTR function, and depending on your center, you have different reference ranges. Again, it's easy access, your nose is there, immediate readout, different than the sweat chloride test, and implemented relatively globally. No, I need this one. It does require some technical skills. There's an age limitation, except for Isabel Sermet, who can do the babies, but none of us can. And in the moment you have nasal inflammation or you do smoke, then you can have low false CFTR measurements. But in the end of the day, the same study cohort here, you again get this nice kind of reflection of the CFTR function spectrum with, it's nice to showcase that, but for an individual patient, there's great overlap between these categories, making it difficult to assess the individual CFTR risk. There's this concept of disease spectrum, and I know you will show that again, but we have used to show these triangles where we say there's on one side 100% function, 0% function, and then there's CFTR dysfunction in between. A new concept has been created, and Isabel will show this probably in more details, but so far, that on one side you have those who have normal function, if you want, and on the other side, those with zero function, and you classify the different phenotypes that hopefully go along with the different CFTR genotypes, if you can identify them, and roughly with a sweat chloride test. But what if these tests don't disagree? What if your sweat chloride doesn't agree with the NPD? And that was a study done again on the pediatric cohort by my friend and colleague, Dr. Oy, who showed that in that cohort, when you do NPD and sweat chloride in parallel, in many cases, they don't disagree. They don't agree, meaning that if you have reference ranges for one and reference ranges for the other, and you classify somebody with CF or CFTR-related or normal, that doesn't match up. And in the end, for those with respiratory or chronic sinopulmonary symptoms, the test agreement was only moderate. It was poor for those with pancreatitis, and fair for those with CBAVD azoospermia. So then what is the solution to that? So one would be to just bundle these tests, come up with a scoring system, which they did in that paper. And the other, as you heard from Carlo before, is to be a little bit more stringent and say, maybe not everybody with a low NPD should be classified as CFTR-related. Maybe it's better to have two CFTR functional tests and diagnostic for CFTR-related disorder. There's been another test being developed. You can take rectal biopsy. That is not so palpable in North America, but well established in Europe. You can do that by rectal suction biopsies, or like a real GI doctor using a colonoscope and under vision. And then you can ex vivo, when you have time, there's no patient strangling, look at CFTR function. And you can see either nice good function, or you can see no function and the traces becomes positive. I think the advantage is an ex vivo test. It's an immediate readout and can be done in all ages. We can sample rectal biopsies from a baby, which they do also to do rule out Hirschsprung's disease. But it is a technique that really requires equipment, technical skills, not easy to set up, and there are not really good data yet available to classify CFTR-related disease patient. Another test has been developed by Dr. Quinton and I, using another function in the sweat gland, which is CFTR at the bottom, needing for secreting sweat rather than just absorbing the chloride in the end. And that's an observation made already in the 80s by Quinton, Sato et al., and Jeff Wine, that there are different types of secretion. One is big and cholinergic secretion that we need to regulate our temperature, and one of these here little tiny bubbles, beta-adrenergic only secretion. Again, it's an easy access test, relatively easy to use, no lab required, because you don't need to measure sweat chloride concentration, and can be and is a little bit implemented in different continents now. There is still an age limitation, and you can have fast low CFTR measurements if you don't sweat. So just to give you an impression, so you can stimulate sweating by intracutaneous, and here comes the age limitation, injection of these different sweat stimulants. And then you have to be really nice to your skin, you have to oil it to avoid contaminants, and then you put these evaporometer probes on, and you get these nice readouts in the ideal case, where somebody with a normal CFTR function has normal beta-adrenergic sweat secretion, somebody who has one CFTR gene variant as a carrier has half of the beta-adrenergic sweat secretion, and one who has two CFTR gene variant and CF has no CFTR secretion. Theo Nguyen from Isabelle Sermet's group has recently published a very nice paper that reflects our observation in Toronto as well, and I present both of our data. These graphs are stricken in the same way. She examined 24 subjects who came in with disease, chronic sinus pulmonary disease, and or acute recurrent pancreatitis, different age range. And these graphs go in a way that on the left side you have some reference pattern, and on the right side you see those where they wanted to test whether they fall in a category of CF or CFTR-related disorder. Sweat chloride is first, then the nasal potential difference measurement, intestinal current measurement, and a beta sweat test. Not everybody got all the tests. The controls, carriers, CF patients, and then the query with 0 mutation or CFTR gene variants, query with 1 CFTR gene variant, and query with 2 CFTR gene variant. You don't have to study all the single dots, it's about pattern recognition. You see here in the sweat chloride range, they all are in the similar kind of range. NPD also, they overlap quite a bit. And that may mean something on an individual level that may matter for one who has better or less function on an NPD. So can't say from these data. And also in the intestinal current measurement, they are on the same level. But interestingly, the beta sweat test that I just introduced to you changes that pattern a little bit, where it separates out those with 0 gene variants from those who have 2 CFTR gene variants and those with 1 in between. And we made similar observations. These are unpublished. We had 45 subjects with chronic sinus pulmonary disease, acute recurrent or chronic pancreatitis, and male azoospermia. Same graphs to make it easier to recognize. I just put one more category. These are healthy controls, heterozygote carriers, pancreatic sufficient CF patient who have a little bit of milder CFTR function with milder CFTR gene variant with oftentimes residual CFTR function, and the pancreatic insufficient. Again, the query 0, query with 1 variant of clinical, of variant clinical consequences, 1 with a CF causing variant, so I made a difference here, and those with 2 CFTR gene variants, not 2 CF causing. So I do that, eh? So again, pattern recognition. So sweat chloride, they are all overlapping here. Like again, it may matter that these 2 patients with bronchiectasis have high sweat chlorides. Can't tell from these data. NPD, you see here the control group nicely separates, but in this query, they do show great overlap. ICM, not everybody wanted to have rectal biopsies. And again, there's great overlap. But the sweat test does offer additional information in that those with 0 gene variants fall into a normal range, result range, and those with 2 CFTR gene variants in an abnormal result range. So while there is on the beta-adrenergic side great overlap here in those who have CFTR gene variants, there's none if you have no CFTR gene variants. So I think Isabel would agree with me if we say, and I don't want to do a new algorithm, just alerting to the fact that maybe new tests come along where you can help sorting a little bit better, that if your sweat chloride and CFTR genetics are inconclusive, the beta-adrenergic sweat secretion test may help to sort a little bit further. Because if you have normal CFTR function on that test, you're unlikely to have CFTR-related disease or CF. You have normal CFTR function. If you do have abnormal function, then this test does not help you to discriminate further. Then you need all your other tests to sort out, are you just a carrier, are you a CFTR-related disorder person, or CF? There could be an extra step in here. A couple of cases to make it more palpable. These cases are all real cases out of clinic. 48-year-old woman coming with chronic silent pulmonary disease. If you have CFTR genetics, you can read that mutation 3849 plus 10 kb C2T. It's a classic CFTR gene variant. This woman actually underwent later on lung transplantation for lung disease. But then if you look at her functional testing, her sweat test wouldn't have put her in CF range. Her NPD wouldn't have put her in CFTR range, in CF range. And the sweat test, the beta sweat test, was abnormal because she has 2 CFTR gene variants. This was an old recording. That was before we changed the software. This is another case with a 25-year-old man with CBAVD. He has 5T on both alleles, which are itself not CF causing. His sweat test puts him in the range of CF, and by definition, he would be CF now. NPD puts him in a healthy control range, and because he has 2 CFTR gene variants, he is abnormal. Still don't know if he's CF or CFTR-related disorder, and I will leave it up to the discussion later how to sort these kind of patients. This is another last patient. It's a 36-year-old man with acute recurrent pancreatitis. CFTR gene sequencing found an CFTR gene variant, which is R668C, and then he's negative on the other, and then he has a 5T. Phase is unknown. So the R668C is not CF causing as per CFTR2 database. The sweat chloride would put him in healthy control range. The NPD was low, can be false low due to inflammation, for example. And the sweat test, the beta-adrenergic sweat test, was completely normal. So this is a patient, and I'm confident, that I would put outside the CFTR-related risk. So within this spectrum that I showed you before, a normal beta sweat test may help to zoom in a little bit further and concentrate only on those who have an abnormal sweat test. But then the question still remains, where to draw the line here? Who is really at risk for CFTR gene variant associated progressive disease, and who is just having a disease and a CFTR gene variant? And it does make it easier to go back to an old observation that we made in a paper that we published now 10 years ago, where we sorted adolescent adult, a patient with chronic silent pulmonary disease and workup for CF or CFTR-related disorder by sweat test, NPD, and CFTR gene sequencing. And when we sort them into different groups, idiopathic, CFTR-related, CF, their disease severity is quite similar. FEV1 predicted is similar, Pseudomonas findings similar, mucoid Pseudomonas similar, even the low Z-score on BMI. So then the question is, does CFTR or how much CFTR dysfunction matters? So in summary, current available CFTR functional tests have helped to develop the concept of CF as a disease spectrum. The disagreement between tests challenges a straightforward diagnostic algorithm. However, exploring these differences may help at one point to better explain differences in CFTR-related organ pathophysiology. New diagnostic tools and more stringent criteria to identify people with a true CFTR-related health risk will certainly help to focus clinical resources. In addition, including patients with CFTR-related disorder in a well-established database, in Canada it will be the CF database, will provide the opportunity to study outcome of comparable CFTR-related disease cohorts. And with this, I want to thank your team, so my team, previous people who built this amazing cohort of CFTR-related disorder, and that was all done under Peter Dury. Collaboration I had with Brazil to get these data, and the CF clinics. Thank you very much.
Thank you very much, Tanya. Are there any questions from the audience? We didn't have any questions yet in the Q&A box.
And we do have a microphone here, so you're welcome to go up.
Okay.
I can start with one question, I guess. There's a number of patients that you do the sweat chlorides, they're intermediate or even diagnostic for CF, and you find no mutations, extended genetics. What would be your next step after that? And is there other diagnostic possibilities?
Yeah. So it's a patient with symptoms, right?
Yeah.
Yeah. So in this case, I think we would all, and sweat chloride is completely normal. Sweat chloride was abnormal.
Yeah, either intermediate or diagnostic.
Or diagnostic. I think in that moment, you need to probably continue on your journey and add on functional tests, and depending what tests you have available, then you see that workup CFTR-related disorder. If you have 2 functional tests that they are abnormal, that patient goes in that category despite of a normal sweat chloride or despite of absence of genetics.
Okay. There's a question from the audience about how available beta-adrenergic sweat testing is, I think, around the world or in the US.
So it is actually not so non-available, but it's easy to teach. It's, Isabel is teaching it on the European side. I'm teaching it on the North American side. Toronto has it. Some centers in the US have it. Brazil has it. Australia has it. Isabel in Europe. So if there's interest to learn that technique, we are happy to teach.
Another question is, might there be a risk for these intermediate patients to obtain a named diagnosis when we are insecure about their prognosis? Would this be a disadvantage for insurance purposes?
Yeah, that's a nice ethical debate, right? Is it important to have a diagnosis, or is it better to be left in the unknown? So what I learned from this CF-SPID, I have a CF-SPID cohort, where they don't have any symptoms. So you're just hanging, you're dangling that genetic risk over these asymptomatic babies when they're babies. And what I learned over the 10 years I'm doing that is that people do want to know. And people learn to live with risk. And people can deal with that as long as they get good information. So yes, please disclose the information.
I think there's important to establish these registries, but what is the risk, I guess, in terms of having some selection bias? Because a lot of these patients disappear when they're relatively asymptomatic or mildly symptomatic.
Yeah, I think that's a good point. I mean, in the end of the day, you can't force people to follow up. And I think it's an offer, right? You can lay out the information that there may be a potential risk you develop progressive disease further on, and we're here to sort that out. And if they don't take up on that, then I agree there will be a selection bias.
Please.
Presentation. Could you comment, just add your comment to the importance of complex alleles in CFTR diagnosis? That is, no clear diagnostic mutations, but with the number of CFTR and genomes that have been sequenced now, we learn things about non-coding sequences and others that might contribute to the impact.
In the CFTR-related disease order world?
Right. In other words, are there mutations other than the ones we think of as causing the disease that since thousands of CFTR genomes have been sequenced now? We'll learn about polymorphisms that might be important in some of these less classic sort of full-blown phenotypes.
Yeah, no, I agree with you. Besides the clinical utility, there's a great academic use, right? And here functional testing does help you. It may be interesting to see that one mutation, splice mutation, has a normal, relatively normal function in the nose, but not in the rectum and not in the sweat. And I think we learn how different tissue may handle that differently, and it tells us about the understanding on clinophenotype relation. Totally agree. Not there yet.
Okay, thank you. So I have the fun job of introducing the debate. So just give me a second. I'm just going to bring up a few slides here. Oops. Okay, so Carlo and Tanya nicely set the scene and laid the foundation for our program debate today. I just want to kind of give you a further background on how challenging this can be. Alessandro Franciosi, who's a fellow working in Vancouver with me, distributed a survey, a case-based survey to across the UK, Ireland, Canada, and the US. We had 55 adult CF physician respondents. We distributed 7 cases, and you can see the heterogeneity and the poor agreement that was had with respect to coming with up with a diagnosis. Case 4, everyone was clear consensus that the case represented CF, but a lot of these other cases where further testing was needed. Some were even considered CF carriers when others would actually diagnose the patient as having CF. So this is a real problem and a real challenge. So just to present the case, we have a 58-year-old lady, actually a patient from our clinic, with sweat chloride measurements of 49 and 55 millimoles per liter. She had been referred for testing as she had intermittent productive cough with growth of MSSA and MAC from her sputum. She had nasal polyposis as a child, requiring surgery, chronic abdominal bloating and cramping, and a daughter diagnosed with CF and homozygous for delta F508. Her just further clinical profile in terms of her symptoms, she had symptom onset at the age of 55. Prior to then, she was relatively asymptomatic, developed after a bleach spill at work. Lung function relatively preserved, FEV1 90%. A CT scan of the chest shows mild right middle lobe bronchial wall thickening and central lobular nodularity. CT sinuses demonstrated hypoplastic right maxillary sinus, but otherwise clear. In terms of GI, she had abdominal bloating, cramping, and constipation, but no steatorrhea and a normal fecal elastase. CT abdomen, interestingly, showed one single pancreatic cyst and no liver disease. She underwent genetic testing. The initial 139 panel demonstrated one copy of delta F508, not surprising as her daughter was homozygous for that mutation. And she had a negative CFTR sequencing as well as negative duplication and deletion analysis. So yeah, we have our expert discussants, or should I say combatants. In the blue corner, we are privileged to have Dr. Isabelle Sermet. She's from the Hôpital Necker Enfants Malades in Paris, France. Pardon mon français. And she brings years of experience looking at genotype-phenotype relationships informed by electrophysiologic measurements. She actually takes referrals from all of France and helps with some of these challenging diagnostic cases. So we'll definitely bring a great perspective to this debate. And on the red corner, we have Dr. Noman Chowdhury from the Virginia Commonwealth University. He's a professor of medicine there and leads the adult CF clinic. So has a very clinically focused, practical perspective on the case. So welcome Isabelle first to discuss.
So, thank you very much for the kind invitation to make this pro and con debate. So, I'm going to try to convince you all that this patient has indeed a CFTR-related disorder. So, I have no conflict of interest to disclose. And first observation is, why is it so important to have a diagnosis clarification for this patient? First of all, I think it's because we want to limit diagnosis wandering for this woman who has abdominal pain, intermittent cough, and she has a CF doctor, so she's probably very well aware of the possible diagnosis of CF for her because of this intermediate sweat test. And she might feel relieved to have answer for her symptoms. The second reason is because we know from several studies in adults with late diagnosis and mild phenotype that making the diagnosis and implementing a CF treatment improve the prognosis of these patients diagnosed late. And as is shown here in this cohort, important cohort gathering more than 350 patients diagnosed in adulthood, showing that older age at diagnosis increases the risk of dying or being transplanted. And finally, because if the patient is diagnosed with a CFTR-RD and carries mutation responsive to highly effective modulator therapy, she might have access to CFTR modulators, and probably these patients know that. But first of all, we have to answer whether this patient has a pancreatic sufficient cystic fibrosis, a CFTR-RD, or is simply a symptomatic heterozygous. So pancreatic sufficient cystic fibrosis in this case, because these patients might have clinical feature of CF and 2 CF-causing mutations. CFTR-related disorders, as assessed by a clinical entities with feature of CF and predominantly a mono-organ disease, and evidence of CFTR dysfunction, but not meeting criteria for a CF diagnosis, in contrast to a pancreatic sufficiency of patients. And finally, is this patient a symptomatic heterozygous? Because CF carriers are at increased risk for a wide range of cystic fibrosis-related conditions because they can have intermediate sweat tests, and because it is known that having a CFTR function at 50% of the wild types contributes to organ dysfunction and multifactorial disease, where CFTR plays a role of a genetic modifier and in association with non-CFTR genetic factors and also unknown environmental factors. So to clarify these 3 potential diagnoses, we can rely on genotypes, searching for variant of varying clinical consequence, VCC variants, which are very often found in patients with CFTR-RD in association with a CF-causing variant or in 2 VCC variants associated in the genotypes. We can also rely on sweat tests or other surrogates of CFTR function, because assessing CFTR function in the context of a CFTR-related disorder is absolutely mandatory, because the level of CFTR dysfunction is inherent to the definition. So it is now quite well known that pancreatic sufficient patients with a mild lung phenotypes have a CFTR activity and the genotypes between 5 and 10% of CFTR normal level, while of course heterozygous are at 50% of normal CFTR activity. CFTR-related disorder are probably between 10 and 30% of the CFTR normal level, and while there are very, very few patients with CFTR-related disorders between 30% and 50% of CFTR activity, as assessed, a large number of from database of genotypes, because the CFTR genotypes that you encounter here are associated with a very low penetrance for CFTR-related disorder. So to investigate the CFTR-related disorder, ECFS has implemented an algorithm for CFTR-RD diagnosis, which obviously begins with an extensive workflow to really rule out all the other conditions which can be associated with the symptoms of the patients, followed by a second step of CFTR extensive gene analysis and performing sweat tests. So this algorithm obviously distinguishes pancreatic insufficient and pancreatic cystic fibrosis and pancreatic sufficient cystic fibrosis when two CF variants, CF-causing variants, are found in the patients, and no disease when you find no variant and a sweat test below 30. When two variants are found, and at most one CF-causing with a sweat test below 60, this is probably linked to a CFTR-related disorder. While when the patient, as in our patient, has a single variant and an intermediate sweat test, or one variant and a sweat test below 30, or when you find in association with the CF-causing variant one variant of unknown significance, the algorithm recommends to perform CFTR function tests, which will clarify between cystic fibrosis when they are in the CF range, between no disease when these functional tests are normal, and when they are in the CFTR-related disease range, which will put the patients in the CFTR-RD diagnosis. So I propose you to go through this algorithm for our patient. So does this patient have symptoms consistent with CFTR-RD? First, she has abdominal symptoms. She has chronic abdominal pain, bloating, and constipations, very frequent symptoms in the general population, but a very interesting study investigating more than 20,000 carriers with more than 100,000 matched controls has shown that indeed there is an increased significance of chronic abdominal pain and constipation in CFTR carriers. This patient has no evidence of pancreatic insufficiency, CFTR is normal, and fecal elastase is above the diagnostic threshold of 250 microgram per gram of stool, but she has a single pancreatic cyst at abdominal chest CT. And the fact to have pancreatic cyst is also increased significantly in heterozygous, and moreover, this has been reported also in chronic pancreatitis mimicking pancreatic cystic neoplasm. So it is absolutely mandatory to know if this abdominal pain could be related to pancreatitis, CFTR-related pancreatitis. This requires more investigations in these patients, assessing the level of amylase and lipase, performing MRI with cholangio and pancreatography, and also performing endoscopic ultrasonography, also to rule out whether this pancreatic cyst could be associated with a pancreas cancer, which is also more frequently encountered in cystic fibrosis patients and CFTR carriers. This patient has had ENT symptoms. She has had a severe nasal polyposis in childhood, so severe that it required surgery. And indeed, nasal polyposis, juvenile nasal polyposis, is increased significantly in heterozygotes, again, in several studies. But nasal polyposis is also frequent in cystic fibrosis, up to 50% of the patients in some series, but is also reported as a CFTR-related condition in patients carrying VCC variants, isolated juvenile polyposis. However, nasal polyposis is very frequently associated with radiographic or endoscopic evidence of sinonasal inflammation, both in CF and in CFTR-RD, a condition that the patient doesn't have because she has a normal she has a normal sinusity. However, very importantly, very interestingly, this patient has hypoplastic maxillary sinus, a feature which is reported but very frequently underestimated in CFTR-RD spectrum because it is hypothesized that accumulation of mucus will limit the formation of the sinus. So this might be indirectly link the ENT symptoms or ENT history to CFTR-related disorder spectrum. This patient has respiratory symptoms. She has intermittent cough, she has staph aureus sputum colonization, and very importantly, a bronchial airway thickening, HSCT, consistent with a chronic bronchial inflammation. And indeed, chronic bronchial inflammation or chronic bronchitis is increased in the heterozygous carriers, but also in the general population. Here has Mycobacterium avium, nodular pulmonary disease. Again, very frequent condition observed in 60-year-old women with no other underlying disease. But interestingly, MAC nodular pulmonary disease is also increasingly reported in heterozygous with a high frequency and a high significance. And finally, MAC is also commonly seen in adults diagnosed CF patients, so late diagnosis with a mild lung phenotypes. These patients often carry genotypes associated with CFTR-related disorder. So these features raise the questions whether these patients can have a CFTR-related pulmonary disease without having bronchiectasis, because she does not have a bronchiectasis at a CCT. And this raises the questions of the link between CFTR dysfunction and chronic bronchial inflammation without bronchiectasis. And this is supported by a series of studies which first provide evidence that chronic bronchitis is associated with CFTR dysfunction, and this is reported in several independent COPD cohorts where the CFTR carriers have heavily sputum producers, and linking that to a potential endotype in heterozygotes linked possibly to mucin secretion. Second very interesting observation is that there is a decrease in CFTR function observed in COPD patients, both in the upper and the lower airway, but also very interestingly in sweat epithelia, and this is observed in COPD, both smokers, previously smokers or non-smokers. And very interestingly, this abnormal CFTR function, which is in the CFTR-RD range, persists after the patient stops smoking, suggesting indeed that there is a mechanistic link between CFTR-RD residual activity range and chronic bronchitis or chronic inflammation. And so this hypothesis indeed requires additional investigation in our patient. We need to know if she has a history of smoking, and we absolutely need to repeat investigation because chest CT and pulmonary function tests were performed 4 years ago. We absolutely need to know whether she has now developed bronchiectasis, which could be a sign of a progressive CFTR-related pulmonary disease. We need to perform again pulmonary function tests and lung clearance index to assess ventilation heterogeneity and go in depth in the pulmonary phenotype, even if the patient has normal FEV1. This patient has a sweat chloride concentration of 49 and 55 millimole per liter, so in the so-called CFTR-RD range. And indeed, there is a robust correlation between sweat chloride concentration and CFTR function for genotypes with residual activity. And you can see here, for genotypes between 5% and 50%, there is a very clear correlation. But this is observed, I should say, at the functional level, whereas at the clinical level, there is indeed an inconsistent correlation between sweat chloride in the CFTR range, so intermediate sweat chloride concentration, and phenotype, because there is a similar proportion of subjects finally diagnosed with CF, CFTR-RD, or cystic fibrosis in those patients having intermediate sweat tests. And this is because there is an overlap of the sweat chloride concentration between heterozygous and CFTR-RD patients. Heterozygous may have a sweat chloride concentration in the intermediate range, and also CF patients may have a sweat chloride concentration below 60 millimole per liter. So it is very difficult in this context to rely on the value of sweat chloride concentration. And finally, this patient has a single variant, delta fibroid-del, identified after sequential genetic investigations. Sequencing whole exome sequencing and screening for rearrangements, deletion, duplications, insertion. But we know that still after this sequencing extensive genetic analysis, 3 to 5% mutations remain unidentified. So we cannot rule out that this patient indeed has a CFTR-related disorder. She has a lung disease, sinopulmonary condition, potentially consistent with a CFTR-related disease. She has a delta 508, heterozygosity, and a sweat test in the intermediate range. So she's there in our algorithm. So at this point, we have two strategies. Either we can perform and screen for additional mutations and identify by this exome sequencing, mainly most frequently intronic splicing mutations, which are very difficult to find by intronic sequencing, and which alter transcript analysis of the nasal cells. So these patients could be sampled for nasal cells and investigate transcript analysis. But again, if the CFTR mRNA transcript in the nasal cells are abnormal, this does not indicate a specific mutations. So this is a very long process. And indeed, the ECFS algorithm recommend to short-circuit this investigation by performing CFTR functional tests, which in fact reflect indirectly the consequence of the genotype of the patient. So additional CFTR function bioassay. So which function bioassay could we perform in this patient? Intestinal current measurement, I should say rather not. Rather not, because they are insufficiently sensitive in these patients with CFTR-related disease and CFTR residual activity between 10 and 30%, because they provide normal tracings from 10% residual activity. We can perform nasal potential difference, and as you can see here, there is a continuum of CF transport associating sodium and chloride in the respiratory mucosa. But as you guess here, investigating the different cohorts, CF patients, healthy, heterozygotes, and patients with a CFTR-related disorder consistent with genotypes with VCC. So these patients are intermediate between heterozygotes, symptomatic heterozygotes, and cystic fibrosis patients. So it is very often difficult to interpret nasal potential difference in patients with CFTR-related disease because of this overlap. So as Tanya says, there is also possibility to use and to reclassify these patients with a new generation sweat test. So evaporimetry sweat test is quite simple to perform. You don't need to be an expert in electrophysiology as for ICM or nasal potential difference. It has been implemented in Morocco, South Africa, so in specific centers. And this also is very simple to interpret. So as Tanya says, adrenergic CFTR-dependent secretion does not work in CF. And indeed, when we tested similar patients as the case study now, so patients having an intermediate sweat test and a sinopulmonary disease, we found that the test was consistently abnormal in CFTR-D patients having finally two VCC variants, so diagnosed as a CFTR-related disorder. So this test might be very interesting to implement and perform in these patients. Finally, we could also perform, if you are linked with a research lab, primary culture obtained either by nasal scrapping, human nasal epithelial cell culture, or gastrointestinal organoids. This is increasingly done, and this is potentially very interesting in these patients because it provides not only the level of CFTR activity, but also allows to serotype these patients and assess the potential efficiency of highly effective modulators. So for example, these patients, delta 508, other mutations unknown, chronic bronchitis, sweat chloride at 45 millimole per liter. Residual CFTR activity, you can observe that in the intestinal organoids and in the nasal cells, and very responsive normalizing in response to CFTR, both in the organoids and in the nasal cells. Finally, the second variant was found after next generation sequencing, which is a missense variant. So to summarize, I can conclude that this patient may have a CFTR-related pulmonary disease. She has an intermediate sweat test, she is delta fibroated heterozygous, and she has a pulmonary disease consistent with a CFTR-related disorder. But we need to conclude other pieces of the puzzle for a definitive conclusion. We need to phenotype better the clinical symptoms and the pulmonary disease. We need to perform CFTR bioassay. I will go for beta-adrenergic sweat tests in these patients, and potentially also study transcript analysis from the nasal cells. If abnormal, we could additionally sequence to research deep intranet mutations, with the final aim that we don't need to miss the opportunity for CFTR modulator treatment, because we do know that highly effective modulator treatments, Calditec or CFTR, are effective if on genotypes with residual CFTR functions, and indeed, if there is evidence of a responsive mutation, or if the serotyping is contributing, this patient might benefit in the future for this treatment. Thank you very much. Now.
We'll leave the discussion to the end, so let Dr. Chowdhury present his side. Be careful, she's pretty feisty.
Just take once. Just start here. Thank you very much. So I have the challenging task of calling this case as a cystic fibrosis. So thank you, Brad and Olga, for having me here. Thank you for all the nice talks, and good evening, everyone. Not this thing? Okay, thank you. I do not have any conflicts of interest with this talk. So the basic thing as a clinician for me here is to tell this lady in clinic, what does she have? I don't have access to nasal potential difference. I don't have access to intestinal current measurements at this time. And clinically speaking, these patients who are 58 years of age, we see a lot. I get about a once a month referral in my clinic, people like those. And they are looking for answers. And sometimes they are confusing for hospital staff. They're also confusing for our CF team members. And we also have to enter data into them and follow some protocols, which are also associated with what kind of diagnosis do they have. So my job would be for the next 10 minutes to convince that a vast majority of these cases can be diagnosed with cystic fibrosis, with sweat chloride. And most of the time, sweat chloride does the job for most of us, for these kind of patients. Genetic sequencing is all what we typically need. And if we think through and with the art of science and medicine, I think we can make the diagnosis correctly without having to go through some of the fancy testing that everybody wants to do. And remind you that the investigation tests like NPD, I just made it up, DND, I don't want to discuss that in clinic as the first instance. Then I want to say ICM is a big no-no. Maybe this is a fairy tale for the future for me for now. And CFTR modulator is the way to go because a lot of people want to take that pill and be healthy. So please keep in mind, we are not going to treat the numbers. We are humans, and humans want to be treated like humans. I want to be treated if I would be seen by one of you, not to have more rectal biopsies, but rather have a pill, right? And if patient is doing well, don't change anything. If I'm doing well, the patient is coming to see me because they have symptoms. If they don't have symptoms, they'll be sitting at home. They're not talking about newborn screen, right? You're not talking about people who are being screened by a normal birth test. They are 58, she has 3 years of intermittent coughing. She has symptoms of sinus disease and nasal polyposis. She also has chronic abdominal pain and a daughter with CF. And she's worried and she's anxious, she wants answer. And if we go through all the detailed questions that my opposite Isabel wants to do, it will take maybe 6 months to 12 months to give her some answer. She will have sleepless nights, she will need sleeping pill, and she will need a lot of other areas to help and be sympathized with. So what are we talking about for the cases that we see in clinic? And I think Carlos touched bases about this slide, so this is from their paper, the recent publication. So what is new here? Up until a month ago, I was thinking like if we are 0 to 10% CF function, that's where the CFTR protein is, you will have CF. If you look at the older publications, they were like 10% to 50%. Usually you have enough protein, you don't have CF. So with this new data and the information in the last 15 years, the information has changed that protein production between 10 to 30% can cause some symptoms. And that's where the gray zone is, and that's where these lines are drawn. So if you have infertility, you have CFTR expression in your tissues or organs there, which are very sensitive to CFTR protein. So a little bit of absent CFTR will lead to infertility because maybe there's less abundance of factors of CFTR protein expression. That's what has been hypothesized, and that leads to more infertility. But all the other things are thought to be progressive. So let me take you back there. This is genetic disease. You're telling somebody at age 58 that this is something progressive. You don't have CF. They were born with this disease. They have genes, and they want answers. They want to know, 58 years of age, that I have this disease for 58 years and nobody told me, or I don't have this disease. If I go with Isabel's protocol, I'll be waiting 1 year to tell them whether you have it or not. So something that I would like to highlight here as well to see, how quickly we can relay that. So there's a range and spectrum of this protein expression that can vary in CFTR. So if you have this, earlier the example was given for a male infertile patient who has got just some chronic sinus disease. So if this person would be somewhere here in this spectrum, so they may just have, enough protein production at about 30%, that they may have some gray zone in the testing of the sweat chloride, which is where they could be borderline. They could have some rare genes, which are not completely diagnostic and seen on testing. And then they could have other symptoms like our patient has, CT scan, which is abnormal. And there's new data like you can have a prognosis of MAC or NTM progression that can be predicted as a biomarker and use CT for that purpose. So the patient had micronodular disease. I don't know how many lobes did the patient have, and also what kind of other symptoms about the NTM AFB smear positivity did they have. Like if they have more severe disease, then they could have this as well. So which can affect our decision. So this is something that a 58-year-old lady has abnormal CT, has got some bronchial thickening, has MAC disease, has borderline sweat test, has 55, and I think it will be difficult to just let them know that you don't have it or you have it from the CF. So let's look at this to see about how about the registry diagnosis? How do we look into the registry for the most of the people who have been diagnosed and mentioned in registry? So about 65% of patients in registry have been diagnosed with newborn screening test. So there are about 10% patients who are typically diagnosed later. So those so newborn screening is a pretty sensitive test that can help diagnose 90% of the patients most of the time. So in this case, she's 58, probably skipped it, and maybe that was not there at that time. So now going back there to this, what is the prevalence of this patient population that we're talking about? And this is about 6%. So about majority of the patients are confirmed to have CF, and then they have this borderline testing, which 1 in 10 chance of having something like borderline. So I would say that sweat test is my first test to go, and cholinergic sweat test is what we typically do. And if you follow this algorithm, this patient is falling in the range of about 55 and 49, so in this category. So the next step for us may be to do the genetic analysis, which our case physicians or people did, and the tests were found to be normal. Now I will go on to the next step, and if I follow the algorithm, I will be landing up here. And if I don't have it, right? So the next thing is if you CF diagnosis not resolved for people if you don't, it says here, testing unavailable or equivocal. So if I don't have it, and if I don't have access to it, then the possibility is that can I call this patient a CF, possibly, as not resolved. Also, in my research for this talk, I also found out that there is no normal limit for sweat test in a normal, unaffected population. There was a paper by Dr. Pam Zetlin, very nice paper. They looked up for 50 years. There was no normal established. And also, sweat chloride is also seen to vary over time with age, CFTR mutations, environmental factors, climate, family diet, and test variability. So how much are we obsessed about that 5 less than 60 or 4 less than 60 to be CFTR-D versus CF? And if I look it up into the registry, my thoughts were, okay, how many people have sweat tests in CF registry? And this is data from 2020. So 90% of the patients have been registered to have sweat tests in CF registry. There's still about 10% patients who do not have sweat tests in CF registry. And then I was looking for it to see how it will correlate to the severity of mutations. It rightly here mentions this, and I think most of us know, the severe the mutations, the higher the sweat chloride. And there's a range here for less severe mutations that it is almost touching around 60. And in the next slide, it goes for rare mutations to be around below 60. So it is not unusual to have people in CF registry to have sweat chlorides who are below 60. And then looking at the mutations, like I think my thought here is to have the genetic testing, and close to about 99.4% patients have been genotyped in 2020 CF registry. So they're about 44% as homozygous, 41% as heterozygous, and about 14% are thought to have unknown or neither 508 or rare mutations. And I was looking for those further breakdown of rare mutations, and I saw here that there were unknown about 600 patients, so this is R117. So in my research, I was looking it up to see that R117 was not thought to be detected on newborn screen about a decade ago. And since it was added back onto newborn screen, the selection rate of newborn turn positivity went higher. And then also in the R117, the 5T amino acid mutation is thought to be more CF causing as compared to the non-CF causing, which is 7T, 9T, 11T, or other Ts. So we have those mutations which are also listed, which are also not confirmed to be CF causing or annotated to be CF causing in CF registry. In this slide, we, thanks to the CF Foundation registry data, looking up from 2008 to 2012, and was interested to see, is it unusual to make diagnosis at age 58 with CF? And the thought here is that there were total diagnoses made about 1,000 per year in the last 4 years or 5 years here. And out of those, the adult diagnoses were about 10%, as what we say, 145. And the average age for all patients was about 4 or 5 years. And average age for more than age 18, people were well diagnosed in their 30s to 40s. And then looking at the various testing percentages in this paper from 2004, authors of this paper looked it up to see in 46 adults, what was the positivity rate for the sweat chloride. So 2 sweat chloride values more than 60 were diagnostic of CF in 30 patients. 2 CF disease-causing mutations were found in 15 patients out of 46. And combination of the two led to a higher increase of about 31 out of 46. And there's a potential difference when that was added to those patients, particularly who did not have a positive or diagnostic sweat chloride or a diagnostic genetic mutation. It led up to a sensitivity or positivity rate to about 37. It went up significantly higher for people who had inconclusive tests, but it didn't feel like that was still 100%, as we have noticed from the previous presentations. Also, looking it up here for the cases in the same paper, they looked it up the breakdown, and you see the sweat chlorides were normal in some folks, they were all pancreatic sufficient, and they had all sort of R117 different kind of mutations there with these different sweat chloride values. And their nasal potential difference had a range of value, and I don't know how well that has been standardized to diagnose patients and differentiate between CF and CFTRD between 10 to 30% protein production. This, again, authors in this paper looked it up and in their data in their center, looked up for more than 300 patients who were diagnosed with CF, and they were interested to find out that people were not following the basic protocol of CF sweat testing at that time for diagnosis. They were going with genetic testing and going back and looking at the sweat test and trying to make a confirmed diagnosis either way. And interestingly, I will highlight here a 44-year-old female in this with these kind of mutations here, a normal sweat chloride. At that time, they used to call non-classic CF or atypical CF, which has been discouraged since to be used and has been removed from terminologies. I think we use it clinically all the time to make it simple for other people to understand and sometimes for patients to understand. So the FE1 is 78%, again, normal sweat chloride, and so not unusual for us to find out. And then looking it up here for the R117 and 5T and 7T and other mutations with a normal sweat chloride here as well in patients who had more than 100% were not classified as having CF. So what about this genetic modifier concept? So I've been hearing this ever since I've been doing CF for almost 13 years now, that 50% is your CF from genes and 50% is your genetic modifiers. So it has been well known and published that CF genetic modifiers can affect CF-related diabetes, can impact your lung function, can affect meconium ileus, can affect height, weight, and BMI. And in this paper, Dr. Blackman and colleagues, they showed up some of the genetic modifier can affect how the diabetes gene can be expressed in CF at a different age. So if you would have to have some of these modifiers, you're more likely to have at about 2.8% more risk of having, 8.3% of total variant, or a higher risk of having CF diabetes as compared to not having these modifiers. Also, we want to know the prevalence of that case to see where the population is, where we are studying. If the prevalence of the disease is high, the genetic testing sensitivity will be higher. So if the same panel mutation is tested in certain areas like Ireland, where the prevalence of the disease is high, if expanding the mutation panel to a sequencing, your detection rate will be higher. But where the disease is not well recognized, like Brazil in this slide, the recognition rate could be lower as compared to where the prevalence is higher. And then there is this concept about the variable consequence gene, where this gene can lead to CF or can do nothing. So it's hard to tell patients that you have CF, or you may develop CF, or you may not develop CF. So that's the other challenge that we see for the CFTR-related disease versus CF in clinics. And then this concept about that not everybody behaves the same, and the genotype does not equate to phenotype. I believe there was a question earlier around this. So there's a spectrum of people who manifest and perhaps account for the environment or the other factors, their lifestyle, smoking, whatever goes on in their life, or exposures, that can affect. So if you have the same lady and have been smoking and have emphysema on CT and will be coming to clinics and have a positive methylcholine challenge test, we'll be calling that patient COPD or asthma, but also you will have those other tests like all the things that we're talking about, the CF and CFTR-related disorders. So the things get very complex as adult pulmonologists when we are dealing with these patients in clinic. The same spectrum exists for a variety of expression in the 508. Does everybody with 508 homozygous present in the same manner? No. There's a range of patients who have a range of sweat chloride values, who have a range of PFT values, as well as the twins who exactly the same genes will have a range of values that they express. So there is some role of modifier genes and how the environments account for this. In this interesting paper, and sorry, I don't know how big it is projected, but it was hard to fit in the slide. Gary Cutting and colleagues many years ago, almost 20 years ago, found out that they had about patients who were referred from clinics who had borderline testing. And they had the common testing done here. And when they had one common gene, they did a sequencing and found out that most of the time they were able to find the gene, one gene or the two genes in people who had the common genes. But people, when they did not have any common, like the initial screening genetic testing, they were able to detect more with the sequencing. And in those people who actually did not have any mutation, like zero mutation on sequencing and zero common mutations, those people still had different variety of FEV1s. You know, you could see 80%, they had a sweat chloride value of about 54%, and they had poly-organ disease. I know that before the recent guidelines, there was this thought about that the mono-organ disease is more likely to be non-CF as compared to the poly-organ disease. But the new guidelines are pushing towards that more specific detail in vivo and ex vivo testing to rule it out, and you can still have poly-organ disease as CFTR-related disorder. I think Brad mentioned this slide here, so it is confusing. Not all the experts agree here. 55 people or so from all across US had this mixture of this red meaning strongly agree, orange meaning the CFTR diagnosis, related diagnosis. So you can see the spectrum is divided. People did not agree among these experts as CF experts if they would agree on these different presentations based on the sweat chloride. So it's hard for me to agree here tonight with this. And in this other similar paper, there was also a push towards how well do you feel the current guidelines help you out recognize CF-related disorder or CF, and the recognition of this seemed to be very poor, so guidelines were not very helpful. Also, there was a need, because of the modulators, to classify people as CF because that's what makes them access to this highly effective modulator therapy. So that's the whole point about this discussion here, to see, can we make that push and give these people something that will be more practical? So where's the controversy? So I think most of the people have discussed this slide, but my problem is here with this. So you have to show in vivo, either with a sweat test or with a nasal potential difference test, or with intestinal current measurement, or some sort of ex vivo testing to prove that you have CFTR-related disorder. And why do I have a problem with this? Because, first of all, I'm going to be working them up just like CF, so, which I do, and most of us do, because if you have problems in any organs like lungs or GI, you will do this workup. In US, we have been doing it. I don't know about Europe, maybe this is something new for Europe, but in US, we have been working up people. We don't have difficulties getting CTs done, CT abdomen, CT chest, and other things to work those things up. Do ultrasound. I've been doing ultrasound liver for 15 years to screen people for CF liver disease. This is something that we have been doing. So why do I have problem with this NPD as a DND and ICM? So this study was very interesting, in which they found out that CF or CFTR-related disorder was diagnosed in 22 of 29 patients with a CFTR genotype of unknown or variable clinical significance. In 51 of 119 carriers and of 35 of 42 patients, of one or no identified mutation. So if you had no mutations, you had 16 patients diagnosed with CF out of, you still had 7 patients who could still not be diagnosed with these mutations, with these other testing, with these testing, like nasal potential or intestinal current measurement. But here's the other interesting part. If 2 CFTR sequence variants had been identified, the outcome of NPD-ICM was consistent with the classification of CFTR2 database. So they were concordant or together. So out of those 26 individuals, so if they had more lung disease, they had more positive. Within the same individual, they had the positive nasal potential difference, but they had the negative non-CF range intestinal current measurement test. So I think one of my questions to the authors would be, how would they tackle the CFTR definition there within the same patient who has a different testing within the same individual? Because that will not meet the same definition criteria that is being mentioned here. So interesting part there that I found out. There is no standard differentiation between, at this time, at that protein level of 10 to 30%. So why do I make a case for modulators? Because of all the things that I've shown you. The different CFTR variants exist, and there are different phenotypic presentations. These kind of disease patterns do help. I have at least 2 patients that come right straight in front of my eyes. One patient had CFTR-related type syndrome, does not meet a diagnosis, but I had to classify him as CF. Had recurrent pancreatitis, GOT modulator, has no pancreatitis, is off enzymes, and doing well. I have another lady who was told COPD, who's 65, and does not have CF, does not meet, GOT modulator, doing well. PFTs went up by 20%, and just not smoking anymore either. So some clinical cases over there that does appeal, at least as clinician. And then there are some other factors that can account that we can, again, the art of medicine help us present that to the insurance companies or to the patient that we don't have answers to. And then the recent paper, I don't know how well you all are also a non-CF use of highly effective modulators. There was a recent study published where people with COPD showed benefit. They actually showed less symptoms, even though the FEV1 did not go up significantly, but they were less, quality of life went up and the symptomatic quality went up. So here is my last thoughts about, as a doctor, when I took the oath, I wanted to help humans and help humanity and people in front of me. So that's my oath. I don't want to do any harm, and I have the person sitting in front of me who wants to get the benefit. This 58-year-old lady, I have to make a decision. I cannot be on the limbo, what do I do next for however long. So in this case, there is an opportunity for me to discuss, to see what can I do to help you potentially, and can we do this pill. She has a pill, one of the mutations that is known, and she has a sibling, not a sibling, a daughter, who has 2 mutations. Could she have a CF highly effective modulator responsive pill that she could benefit from? So recent publication here again from Gary Cutting and other colleagues here. And I think if you have a CFTR modulator responsive mutation, they were supportive, unless you have CF diagnosis. So I'm just stretching this thought process here. So I do have a CF responsive mutation. Can I use highly effective modulator in this person and classify this patient as CF? And the other questions that were asked in this presentation were, is other further diagnostic testing required? Well, for academic interest, we can do all the other tests. I can consider modulator, and I will follow this person just like I will follow a CF person. So in the end, I would just conclude that you can decide who won the debate. So one of us, either Isabel or myself, we both have 3 kids, and she has more pets than me, but she drives a nicer car. I drive an older car. She is, daily interviewed by the highly esteemed papers. I'm sitting in small Virginia in a small hospital. Nobody asked me anything. She is the author of many guidelines and papers, and I'm the one who just reads those guidelines, even though I don't follow those. She has 3 pets, and I have 0 pets. I cannot tolerate pets, sorry, Isabel. But finally, I want to conclude here that she is the esteemed scientist who works with this all the time. And do you really want to trust her or want to trust a clinician who sees a patient but doesn't do anything like that? Thank you.
So we open the floor for any questions, if you don't mind coming up to the microphone. I can ask one question. There's a few questions related to the insurance implications of putting a diagnostic label to these patients. Would you like to speak on that?
I think this was discussed in the physician grand rounds earlier. So I think the questions are like, do you have any medical problems or something basic? And are you going to have medical benefit? So the answer to those are yes, and really insurance companies are okay. But they are looking at the 508 the home settings. So in my experience, as long as that is there, and the medical indications are there that you are going to benefit the patient, that is going to.
Is there any differences in France?
So in France, you can give CFTR modulators for very specific mutations. So that's very important. And I would like to say that I disagree with my colleague, my controversy that, I think we need to give CFTR modulators not as a diagnosis test, but according to the anticipated effect we expect in the patients. First, because it's an expensive drug, because there are also other patients that need these drugs, not in the US, but in other countries, patients cannot access. So we should also be aware of that and have a thoughtful use of these drugs. And second, I think we don't know yet all the side effects that this drug could have, so we really need to prescribe these drugs with indications, because we think that the patients are going to be responsive. The second point is to clarify that my workflow is not going to be performed for 1 year. Beta-adrenergic sweat suppression is really only half an hour test, and you can have the answer just at the end. And I do think that it is far beyond ICM, which is absolutely not useful in this situation, or MPD, very, very useful tests. So I would advocate to do only beta-adrenergic suppression, and I am not a wild doctor doing so much harm to the patients.
Go ahead.
Thank you. So as an adult pancreatologist, I'm enamored with the prospect of using CFTR modulators for CFTR-related recurrent pancreatitis. Unfortunately, CFTR-RDs haven't been necessarily approved as an indication, so I would like to hear your thoughts. Perhaps it's a case of trying to stretch the diagnosis of CF to encompass some of these patients, or do you have any other kind of thoughts on how we get these approved, and maybe what are your thoughts on the safety of using these medications if they haven't been formally studied?
So I can answer first. So in France, actually, and for pancreatic CFTR-RD patients who have really symptoms, we can prescribe these drugs, and indeed, these patients, and it has been already published, these patients improved, and it's probably because you improve not only the correct, but mainly the bicarbonate secretion in these patients.
Can I ask you a short question, Isabel? Do you call them these patients to which you prescribe your modulators and who have recurrent pancreatitis? You call them CF or a CFTR-related disorder? Because you treat them as CF.
So I would follow the algorithm. So we would possibly measure, if possibly, the CFTR function. But so yes, it's difficult because so they have CFTR-related condition. But again, if it's a mono-organ disease, we could call them a CFTR-related condition. But if you have a clinically symptomatic disease in the lung, maybe they could be pancreatic sufficient patients. It's here that we have the gray zone if we base that only on the clinical and genetic conditions. Again, I would also say and highlight that, as Carlos says, genetic the genotype, based on the genotypes, is indirectly also indicating whether this patient is CFTR or CF, because they are surrogate of CFTR function.
Great. We'll just take the last question.
Hi, I just wanted to know your thoughts. As a pediatric pulmonologist, we have a situation that's come up that's sort of hard for me to justify in my head. So we have patients that have a sweat test that's normal, but they'll meet, say, criteria for a modulator because they have 2 CF causal mutations. And their outcome measure for successful modulation is a decreased sweat test. But then you have a patient who only has 1 mutation, but a sweat test of 58. And we say that that doesn't justify using a genetic modulator. So the question is, what do we do in those situations?
It's a child. It's a child.
Okay, so it is already known that you have specific CFTR variant associated with negative sweat tests, for example, the 3A410KB, and there is a list that also is highlighted in the paper, where you must be aware that you can have a normal sweat test and the patient has indeed a CF diagnosis. So, if the patient has a sweat test as 58, so very close to the threshold, probably, and so I guess this patient has also CF symptoms consistent with CF.
So say they even have a rate of 45 with bronchiectasis and 1 mutation. Would you feel more comfortable giving a modulator in that person or an asymptomatic?
And so could these patients be further explored, investigating, for example, beta-adrenergic sweat test? That would be a simple way to classify these patients who have probably CF.
Okay, in the interest, Norm, do you have anything? Okay. In the interest of time, we're going to wrap up. We appreciate everyone sticking around to the bitter end here. And like all great debates, there's no right or wrong. So great discussion, though. Thank you.